Good morning. First, I'd like to present my congratulations for the organization of this Congress, and for the invitation. I'm going to speak about our modest experience in the primary repair of the obstetrical plexus. The incidence of obstetrical brachial plexus palsy remains high in Tunisia. At the Children's Hospital of Tunis, we had used to see about 100 new cases per year, and a nerve repair was necessary in 12% of cases. This high percentage is due to a recruitment coming from the countryside of Tunisia, and foreign patients. The aim of this study is to clarify our current surgical selection, and to present our results. Our surgical selection is actually based on predictive elements of poor outcome. The most important predictive element is the recovery time. Indeed, fast recovery reflects a benign lesion, such as neurapraxia or axonotmesis. But a delayed recovery reflects a more serious lesion, affecting indinurium and other connective tissue lesions. In the most severe injury, the roots are avulsed from the spinal cord. That has no potential for spontaneous recovery. So, more recovery occurs slowly, worse will be the outcome. For upper palsies, we are convinced that earlier the biceps recovers, better would be the outcome. Evaluation by 6 months of age allows to distinguish 3 groups. The patients who had good recovery of the biceps would not require nerve surgery. The patients who had no recovery of the biceps should be offered nerve surgery. Preoperative MRI would be necessary to detect preganglionic root avulsions. For the third group of patients who had hesitant and timid recovery, we could do immediately an MRI, or to give oneself further 2 or 3 months to decide. For total palsies, the indication for surgical repair is based on the presence of tearing signs, the biceps recovery time, but mainly on the hand recovery. At the age of 6 months, MRI should be applied in almost all cases, unless patients who had good recovery at the biceps and at the hand. In these cases there is no indication for nerve surgery. In cases of no recovery of biceps, or presence of root avulsion signs, the indication of a nerve surgery is evident. In cases of intermediate recovery, the nerve surgery can be indicated immediately, or within 2 or 3 months. It depends on the MRI result. So primary surgery was performed in 159 cases, in 13 years. Our patients underwent exploration at an average age of 9 months. The average age was quite high, because many babies were seen for the first time at the age of 8 months or older. The study of the results will be limited to the upper palsies with a minimum follow-up of 1 year, and to the total palsies with a minimum follow-up of 2 years. For upper palsies, fortunately, the more common upper plexus injuries were the extraforaminal ruptures, thus repairable. Priorities were always elbow flexion and shoulder control. The repair is most often a nerve grafting. If there were root avulsions, an internal and or an external neurotization would been done. The shoulder was evaluated according to the Gilbert's classification, with a mean follow-up of 4 years 4 months. Before surgery, almost all shoulders were quoted 0 or 1. After nerve repair, shoulders have progressed to stage 2 in 61% of cases, and to stage 3 or more in 24% of cases. However, in 5 cases no progress has been noted in the shoulder. It should be avulsed roots, who have remained intraforaminally. Preoperative MRI have not been systematic at that time, and in those explorations, we saw root continuity into the foramen, with a little neuroma. In one case, the parents accepted to do the SYMPOSUM and the modified Oberlin transfers, for their child, 1.5 years after primary surgery. Otherwise, from these 57 upper palsies, 24 underwent secondary surgery. All patients who underwent secondary surgery are passed to a stage 3 or more. Thus we hope a similar progress for the other group after secondary surgery. The comparison of shoulder results, depending on the age at the time of nerve surgery, didn't show a statistically significant difference. For the elbow, only the 5 cases of avulsed roots did not recover elbow flexion. The modified Oberlin procedure was done to 1 among them, and triceps transfer was done in 2 cases. According to the classification of Gilbert and Raimondi, the elbow became good in 84% and intermediate in 11%. The comparison of elbow results, depending on the age at the time of nerve surgery, didn't show a statistically significant difference. For total palsies, priorities were hand, elbow flexion, and shoulder function. When surgery is done at an advanced age, some babies looked like starting recovery of a discrete finger's flexion. Thus the choice of nerve repair type is sometimes difficult. Thus an internal neurotization was performed to the lower trunk in 29 cases, and a neurolysis was done in 27 cases. With a mean follow-up of 4 years 10 months, the shoulder has progressed to stage 2 in 34% of cases, and to stage 3 or more in 64% of cases. All patients who underwent secondary surgery on the shoulder passed to a stage 3 or more. The comparison of shoulder results, depending on the age at the time of nerve surgery, didn't show a statistically significant difference. The elbow became good in 90% of cases, and intermediate in 10% of cases. The comparison of elbow results, depending on the age at the time of nerve surgery, didn't show a statistically significant difference. The hand was evaluated according to the classification of Gilbert-Raimondi. A hand is considered functional if it has at least 1 lateral clamp with thumb. In our series, the hand became functional in 66% of cases. Among the 56 total palsies, 11 patients underwent secondary surgery at the forearm, wrist or hand. The comparison of hand results, depending on the type of treatment of the lower trunk, didn't show a statistically significant difference. The comparison of hand results, depending on the age at the time of nerve surgery, didn't show a statistically significant difference. In fact, we think that the division of the total palsies into 2 different treatment groups made the comparison of the results at the hand, according to surgery time, difficult. The small number of certain subgroups upset the statistical study. This is an example of an upper palsy. This child was operated at the age of 6 months. He underwent a nerve graft from C5-C6 on the upper trunk, and a neurolysis of C7. The 3 videos show the excellent result at 5 years old. The same type of lesion in an 11-month-old girl. She underwent a nerve graft from C5-C6 on the upper trunk, and a neurolysis of C7. 2.5 years after the nerve graft, she had no active external rotation of the shoulder. A Hoffer transfer was done for her. On the right, you note the recovery of active external rotation, and the improvement of shoulder abduction. The same type of lesion, and the same nerve repair, underwent to a 10-month-old child. 2 years 8 months after nerve surgery. In addition to shoulder sequelae, he had biceps, triceps co-contractions. He underwent a subscapularis release, a Hoffer transfer, and a disinsertion of the triceps long head. You see on the right, the improving of elbow flexion, and shoulder function in general. This is a total palsy case, operated at the age of 10 months. The child underwent a nerve graft from C5 to the upper trunk, and from C6 to the lower trunk. Secondary surgery was done, at 5 years old, Hoffer transfer, and disinsertion of the triceps long head. You see on the right, the improving of shoulder function and elbow flexion. He keeps a weak wrist extension, which needs a muscular transfer. This is a total palsy case, operated at the age of 6 months. The child underwent a nerve graft from C5 to the upper trunk, and a neuratization of the suprascapular nerve by the spinal accessory nerve. C7, C8, T1 were neuralized. Secondary surgery was done for shoulder sequelae, at 3 years old. You see on the right, the improving of shoulder function and elbow flexion. A flexor digitorum superficialis opponens plasty was attempted to improve thumb opposition. You see on the right the discrete improvement. In the end, this is a total palsy, who had nerve surgery at the age of 15 months. He underwent a nerve graft from C5-C6 to the upper and medium trunks. C8 and T1 were neuralized. Secondary surgery was done for shoulder sequelae, at 4 years 4 months old. You see on the right, the result at 6 years old and at 10 years old. In conclusion, the particularity of our series is the timing of our surgical selection, and the high mean age at primary surgery. For the results, the best are those of the upper palsies. We think that microsurgery not only improves function in selected patients, over what would be expected from the natural history, but also increases the possibilities for secondary tendon transfers. Our work has found no significant difference in the results at the shoulder and the elbow, depending on the age at the time of nerve surgery. The analysis of hand results is difficult, due to the coexistence of two important parameters, the age at time of nerve repair, and the treatment applied to the lower trunk.